Josefa and I are going to talk today about changes in blood pressure, very specific to Parkinson's. Sometimes you hear it referred to as postural hypotension. We usually more frequently call it orthostatic hypotension, but we're going to talk about the different components of that this evening or this afternoon for you
Yeah.
folks.
And while some people are coming in, I can give you the background. So we were challenged by one of the care partners that we think will be here today, although the husband it's his birthday. So if you are online, happy birthday. I even humorously thought, oh, now that's an interesting gift to give your husband, a talk specifically for your problem.
Yes.
So yes, you are welcome to always challenge us to bring forward things that you might be dealing with. I must say that I was actually in nursing before I became a physiotherapist, and the first time when I heard about hypertension, let me see, I don't think we have much to say. And then as we dive into it, I was positively surprised how much how much solutions we have and strategies, and so it was very exciting to put this together for you, to organize everything that we hear sometimes in talks. So hopefully, we can share that with you today. That will be our goal.
Yeah, I'm also pleasantly surprised by how treatable it is. It's something that you can definitely manage if you get the right approach with your doctor.
Our main goal is really to focus on low blood pressure when we are changing position. So it's not about us understanding how high it is or how low, but it's the transition that we're going to be focusing on. And why? It's because this is a specific problem that people with Parkinson deal with. And what we thought for the talk was, so what would be relevant for people to know is, one, I think understanding how the professionals look at the problem might be interesting. So give you a global vision about how the doctor is looking at the problem. And then also maybe how should the person with Parkinson and family that are helping and care partners be able to also structure a plan to be able to handle such a problem. So even if we're not dealing with this type of issue and challenge, I think it's important for people to know that it exists and that there's so much that we can do. So our second focus, and I would say primary, will be to share with you several non-pharmacological strategies that have been recommended and studied for low blood pressure associated to changing position. Okay, so that's our plan for today. And we'll start with this view about, so how would professionals look at this? You go to the doctor's office, you complain, I'm feeling foggy, dizzy when I change position, and that brings something to the mind of the health professional, and this will be the structure that he will follow. So sometimes there's more freedom to what the health professional might choose, but actually this is interesting because it's step one is to always find and manage the underlying causes. So the focus will be, let us try to find out why this is happening. Okay. The next step will be, while we're trying to find out what is happening and what if we can't find the causes, there is several things that you can do immediately that will help you control the situation. So that is what we call the non-pharmacological and lifestyle changes that people can do. And hopefully tomorrow, if you don't know some of them that you hear today, you can integrate it right away. And then, I say then because it's biologic, if necessary, then you have changes in medication. So it's one thing if we find that one of the medications might be causing low blood pressure, and so that means it's the first step. Let us find the cause and handle that. But in this case, it's like, yes, there is medication that can either increase it or decrease it. So there's also solutions at that level. We will not be focusing on names of medication today. As you know, it's like we want to focus on giving you strategies so that you can use tomorrow. Now, if we look at, so what can we do with this? How would we approach it if I'm a care partner, if I'm a person with Parkinson? This is globally, these are strategies that we usually share with you for most of the symptoms that the person can have a Parkinson, but specifically, first step is the giving competence and skills so that you can be able to identify the problem. So learning how to identify a symptom, something that's different. There's a change in how the disease is supposed to progress slowly, and there's a change, and being able to identify that immediately is really key to being able to manage any symptom, right? Our next, I would say, skill that we want to provide is helping people understand how to report it, because the way we say things will influence the result of how the doctor may look at it in a more urgent way or not. So I think taking advantage of technology and doing these talks, it's really good to be able to provide this type of knowledge for people to have and to use. And then we're crossing over with the perspective of immediately what will happen is your total focus will be on trying to manage whatever is causing the problem. And one of the ways that we can do that will help us is if we are able to understand the symptoms. So what makes it worse, what makes it better, are two key strategies for you to be able to report it better as well, right? Trying to understand, is it more in the morning? Is it more at night? Is it when I take the medication? Is it when I get out of the shower? Is it after eating? These are precious information that the health professionals need so that they can get quicker to a better treatment. And then, as I said, the next step, crossing over, is, okay, so there is a whole bunch of non-pharmacological strategies, so strategies that are not based on medication, that people can apply in their daily lives, and that will make a significant change. This is one that we also like to add, which is fortunate we have access to more information nowadays. It's making sense of that information that becomes now the challenge. But I think keeping updated on everything about Parkinson might be quite challenging. Keeping updated about something that you're dealing with, I think, is an interesting way for you to also manage that specific problem. So, of course, we can't, this is one symptom in the middle of this big, enormous list of things that may happen in Parkinson, and it can be very overwhelming for people to just, okay, keep updated with everything. But if you are dealing with it, even more important for us to be able to share this information. Good. So let us think about, if we focus, let me get on, I would say diving a little bit deeper into each one of these, I would say, steps for you to help you manage it better. So learning how to identify. Now, one thing that's interesting, we can have this problem, low blood pressure when changing position, without symptoms, right? So it's important for people to monitor this, to ways to measure it, and we will get into that as well. But most commonly, it's something that people will associate when I change position. I feel some lightheadedness. Loss of consciousness is already an extreme, right? So I feel that woozy. There's certain words that people use to describe this that we will also share with you because based on the questionnaires that you guys shared with us. Then we have things like that you might recognize less. So feeling fatigued, interesting. So fatigue can be a very complex symptom on itself, but when I change position, I feel this weakness, sometimes even in the legs trembling. So this could be associated with an episode of low blood pressure. How about blurred vision also? So in the lightheadedness, my vision might be more compromised as well. It's more recognized. This one less so, which would be pain, what we call hanger coat, if I'm not coat hanger.
Coat hanger pain.
Coat,
yeah.
Which means it's basically reaching here your cervical and both shoulders, and you feel that type of pain. And because these muscles are really sensitive to this, of low blood pressure, you might even actually feel that tension, that pain, and it's associated to that. Okay. Not so commonly, right? And then I think symptoms that we recognize as well is taking more extreme. So in situations that are more severe and things that would concern us, and maybe sometimes it delays in people managing it, is only when there is a fall that is associated to dizziness, so fainting. That would be the extreme. And we hope that with this type of talk, we can help you not get to that point before acting. And I wouldn't say novelty because we've known this for some time, but the truth is it's also highlighting how when the person changes position and then sometimes the family's talking to you or someone's talking and you are having difficulty processing the information. So that means there's cognitive changes. You can't really understand what's going on. and difficult to act, which also would be related to this type of episodes. So keeping out for these symptoms helps you, if they are happening, to be able to contact the doctor and to understand how you're going to report it, which we'll go into next. But before that,
well, and sometimes those changes in cognitive function might be the domain where the care partner is seen as the person experiencing it is going to have a loss of kind of temporal orientation for a second. So they're not going to be as aware of it as you will be. So this is something that you might see externally more readily than someone living with Parkinson's might report to the doctor. So just to kind of speak a little bit to changes in cognition associated with this, I mean, we're talking at a very global level of this real transient. You get from a seated or more often a lying down position, you stand up, you have the change in blood pressure, and therefore you have this moment where you don't have enough blood flow, and that might be where your vision gets a little blurry because you're not getting enough blood flow to the retina, or more commonly in your brain, and it makes you a little bit foggy or lightheaded. That's very, very common, and it's a frequently reported issue. It's a good reason why you'd want to address that, because it could be very dangerous. But you can also have just lower volumes in general, and that could also influence cognition generally. And when I say generally, we're usually talking about executive function kind of being you're maintaining awareness and keeping track of items and pacing and organizing and sequencing. And so it can have an influence just on cognitive deficits, and that's not just for Parkinson's, that can be for anybody dealing with orthostatic hypotension. We don't quite understand in Parkinson's particularly whether this is simply one causes the other. You have this lack of blood flow, you don't have enough blood flow, therefore you have changes in your cognitive function globally, or if it's the other way around and it happens to appear at the same time because you have that lack of blood flow. So we don't really know chicken or egg on that per se. One thing that's interesting is that we do notice that frequently it seems that people who are experiencing orthostatic hypotension in Parkinson's, and that's usually about 20% or so, 1 in 5, it's a higher risk associated with changes in cognition that we call mild cognitive impairment, and more importantly, Parkinson's disease dementia, which would be defined in a very specific set of guidelines. And so people who are experiencing that, particularly if they're women, because they tend to regulate better, they tend to cover better, they don't often get the kind of care that they should get for that. It may go unnoticed, but there's definitely an increased risk of dementia over time.
So we distinguish between in the moment that it happens, so that's temporary difficulties with cognition when it's happening, and then now we know that it's also a risk for having cognitive difficulties. And I think we are highlighting this particularly because there was a question in the questionnaire about it, but not only, because I think it helps us also get a little bit more motivated to act upon it. And it's good that it's an issue that people can act on it. So there are solutions, and so to keep it in a positive note, identifying risks and then having solutions is more positive. Right?
And that's a takeaway when we were talking about this before, as we were doing the learning for this. We're always worried about changes in cognition. It's a very common concern. And here's something that you can actually do to address it. So it's one of the more fixable approaches, and it can always benefit in much more global ways. So it's another reason why you want to try to attack this problem if you see it, because it could have significant improvements in your quality of life in a way that some other things aren't necessarily as treatable. So I'll leave it there.
So I want to highlight that the information that we organized here for you today is based on the questionnaire that we send out to everyone, so that we can get a feeling about how this is impacting you. I think the questionnaires also help you see how complex it can be, and also it's already an educational tool on its own, I think. And so we'd like to share with you, your voices. So basically the people that answered the questionnaire, thank you for that, because it contributes to the specificity of this talk. And these were the keywords that people would say when we talk, what type of symptoms do you experience when this happens? So let's see the keywords that we were talking about. So slight headiness, absolute need to sit down, paleness, yawning, then freezing. So there's a certain connection here. Freezing shows up twice, which means the feet feel glued to the floor. So you can imagine if the person stands up, there's a loss in terms of even cognition. Cognition is related with this freezing as well. So I would probably link it through there, although we do not know. There's not research to it, and I think there should be. Then we have, again, lightheadedness, inability to maintain balance, falling. So dizziness again, never sit down as the symptoms go away quickly. So this is an interesting point, which is what people do when it happens, and we will come back to that as well. And then at the more at the cognitive level. So what would people complain about in terms of cognition would be me feeling fogginess. The word that is curious, woozy. He says he gets woozy and at times will freeze. Again, the connection to the freeze. He does not think straight, and I can't get him to sit on a chair that I have moved close to him. He does not seem to comprehend the directions that I'm giving to him. So this is a care partner sharing that the cognitive challenges that are happening to it. So hopefully we realize that it's part of it, the understanding that we might have to use more non-verbal cues of touching and guiding the person to sit down instead of talking, because the talking will probably just increase more the confusion. So if I had to say something in terms of tips, I think that would be bring the chair close and then slightly guiding the person to sit down so they understand what is intended. Okay. So if we want to try to not miss it, so this was like, okay, three key questions that you should keep in mind so that you don't miss this problem. And the first one is the triage question that the doctor should ask in terms of consultation. So there's specific questions that we associate to this problem, and this would be the question that would be asked to you like if you participate in a research study or if they're doing all the real assessments for Parkinson. So when standing up, after sitting or lying down, does you, in this case, or loved one, experience lightheadedness, the keywords, dizziness or weakness, or is no longer able to see properly or think clearly? So you can see in one question, you have it all. The transition of position and the keywords dizziness, weakness, no longer to properly see and also think. Okay. Now, while answers that we can share with you that people answered, it was I would say very balanced. We have here the group. So I'd say the majority of the people are reporting to feel dizziness or foggy feelings cause me to hold on to something, but I do not need to sit or lie down or lie back down. So in these descriptions, when I say that, I think the question is already very educational. You can see what the professionals are aiming for, right? You can see what are they considering something that is severe, right? If it makes you have to sit down, causing you fall, as you can see, would be the most severe situation. And sometimes these things are not so clear, right? And you can see no dizziness or fogginess is also a criteria. We have a different distribution, so that means people are dealing with the extremes here. But I think it's always interesting to see what are the clinicians looking for when they ask you the questions, right? The second question to also keep in mind would be how long after standing do these symptoms typically appear? So, which means that it's not a question of only when you transition, it can be delayed. So it can be 3 minutes after, 5 minutes after, and just keeping that in mind that it doesn't have to be immediate where you feel that. And then also standing too long. So if the person is in the standing position for a long time, and then this can also happen. So 3 different ways to look at the problem. So our challenge would be, the next one would be, okay, how do I contact the doctor? You guys have nice electronic reports, my chart, if I'm not mistaken.
Yep.
You have a certain amount of words that you can write to the doctor. So you really want to use that space as best as you can. I think it's more than this. So just giving you an example of maybe how can I call the doctor's attention with the right sentences. So imagine something like, dear doctor, I have been experiencing a new problem So it's important for us to understand, compared to the last time that he saw you, how new is this, right? So it's a novel. Is it something that it's the same symptom that you have, but it's just getting worse, or is it something new? So the novelty factor is important. And then we say, when I stand up, I feel dizzy and weak, and sometimes making me feel like I might fall. Okay, this gives us a notion about how it's impacting and how severe the symptoms are. This feeling goes away as soon as I sit down. So that helps us understand how you are controlling it, and again, the impact that it's having. Imagine we write then, it happens every day. So the frequency that this is happening. Imagine it happens once, you went on holidays, you went into the sauna, and it happened once, right? Or it happens every day. The severity is completely different. The attention that we're going to give to the problem is completely different. Being specific, it usually happens in the afternoon after I eat. I also perceive it when after I take my Parkinson medication. Relating any symptom with Parkinson to when you took your medication is very important, so that we can see how the medication is affecting or not the symptom. Okay. It seems to be getting worse over the last 2 weeks. So again, it's impacting and how it's getting worse, what makes it worse. It prevents me from going out for lunch with friends. So if this is happening after lunch, right? I have noticed that it is better if I stand up slowly. So there is already some study about what makes it better. And then very important is how everyone else around us is perceiving the problem. My partner is often worried that I might fall. So as you can see, it's just 3 paragraphs, but it says so much that it really helps the health professional come back to you with specific instructions that can help dominate the situation immediately.
So once you get in with the doctor, I mean, that's a nice message on my chart so that you can get it to your doctor quickly. They'll probably want you to come in for a visit. This is not the kind of thing that they're going to want to wait until your next basic call. They'll probably want to see you. They're going to review medical history, medications, and perhaps medications that are causing or exacerbating this. And then they'll do an exam and diagnose, probably with some blood pressure monitoring. So they'll probably take your blood pressure while you're lying down, and then have you stand up, and after 3 minutes take your blood pressure again. That can be sometimes why, if you just go to a regular PCP for a normal visit, they might not catch something like this, because you really have to be in a situation where you are in the lying down position, the supine position, and then standing up, because that's where the issue is going to occur for Parkinson's. They can do some additional testing, electrocardiograms, and maybe a tilt table test, which will do a lot of the same maneuvers. And either they're going to come up with a diagnosis of orthostatic hypotension, where it's having that change, that blood pressure drop 20 points in the top number or 10 points in the lower number. You could have it happen in a delayed format, and that's more than 3 minutes. Usually you want it to show up in the first 3 minutes, but in the literature you could see it, even 20 minutes later, or after doing some kind of activity. And then kind of getting back to what somebody put in one of the surveys, you could have some initial orthostatic hypotension where you actually have the problem, but it seems to resolve itself pretty quickly. After the doctor's gone through and identified that, then they're going to try to rule out some of the other particular factors that could cause this, that could precipitate that. And I think dehydration's at the top of everyone's list when you do that. And then medications if you've had anemia or something else like that. So these are the things the doctor is going to be looking at.
Yeah, so just thought so you understand the behavior behind it. So this was an example. So if it is something related to identify medication that might be causing it, and then that means you solve it by just stopping it, or changing the dosage, or changing the time where you take it. Like imagine you're taking hypertension pills, and then you take it in the morning, but that's affecting. So you can negotiate. I don't want to go into details regarding this, because it's about negotiating. The word's probably wrong. Yeah. With the doctor about how can I manage this, right? Because you might have different doctors giving you different medication, and so hopefully they are able to talk and communicate, and they can get to a plan, because no one wants to get into each other's prescription, but you have the cardiologist doctor that gives you something, and then the neurologist gives you something. So it can be complex, I can imagine, but hopefully we can get them to talk so that they can manage that.
If I could be a little biased, I think your movement disorder specialist is going to have the best global, and they'll be able to consult and provide guidance to maybe somebody's giving you a depression medication or something for urinary or something like that. Some of the causing medications. Because
they gather the knowledge that we know that with Parkinson, you already have a tendency to have low blood pressure. The medication on itself, levodopa, we all know that it also lowers as well. So I think just having that talk with the other doctors so that we understand that there is a transition and that there's specific moments that you might have these fluctuations which make it challenging, right? If it's high, if it's low, if it's high, if it's low.
Yeah.
So this would be one example. Obviously, that means talking with your doctor and exploring all the options. And then, as John was saying, so the dehydration is always on top of the list as well as identifying it.
Especially in the morning. I mean, overnight, you're drinking less fluids before you go to bed. Maybe you get up in the middle of the night to go to the bathroom. And when you wake up in the morning, you are at your least hydrated. And that's probably when you're at your highest risk for this kind of problem. So you want to start hydrating early and then tapering off later in the afternoon or evening.
So imagine in all this process, you identify that, oh, wow, okay, so I'm feeling dizzy because I'm not drinking enough water. And sometimes the solution is so simple that it's so hard to do, right? It's because it's like, no, it can't only be that, right? But this is amazing when we think about, okay, if you do drink more water, the problem will reduce. I would boldly say go away, right? Because it's the causing factor. If this is the underlying cause, then you solve it by drinking water. I was like, how can we convince people to drink more water just based on this? That is a challenge, right? Because we all know that drinking more water is important. But the truth is, it's not. It's challenging to tell people to drink more water. There's lots of motives. Being the primary one, people are scared to drink more water because then you have to go to the toilet more times, right?
The mobility issue.
And then going to the toilet is a bummer because you have to, put your. There's a lot of logistics going on there. But the truth is, it seems to be a solution. Just like exercise, it seems to be a solution for almost all the problems. I would say the challenge for the health professionals is how can we be able to transmit this message as best possible in terms and also discuss strategies, and we will go into that as well. Okay, so I'd say when we think about the next step, which was, can I during the day, let me study the behavior, right? So for 2-3 days, dedicate yourself to let me see how this happens throughout the day. Ideally, you'll even have a little diary where you register this. So it's just identifying there are, I would call them personal triggers. So something specific to you that might bring on these symptoms. That might not be reported in the literature because there are things that we already know based on what people tell us, based on also factors that have been identified. So things like it's worse after eating, it's worse, when drinking alcohol. These are things we know, and that it's good to share with others so that you are also attentive to this. But I do want to identify there could be something very personal to you, right? And it's hard for me to give examples because sometimes it can be really, really different. So if we think about the question that we challenge you to think about these triggers, and these were the responses that we had. So for the answers were when we're walking in the summer heat. So again, we have heat as a keyword. Not being hydrated, here comes the water. Simply not knowing. Again, if I, ask the people that are with you, because sometimes you'll be surprised that others might identify the problem that maybe you won't, something that brings it on. Stress, feeling tired, interesting. Particularly when rising from a car seat. Well, that is, imagine the summer heat and you're getting out of your Ferrari. I'm playing because obviously I'm highlighting the fact if the car is too low, then you have more of a transition and effort to get out of it and might be more problematic. Hopefully you have a nice big car like Sonia and you just slide out. But no, so we have more things like, no, it happens unexpectedly, so we might not know, but frequently it is early in the morning. From lunch on, it's fine till supper. which is something that we know from the literature, that usually these symptoms are more severe in the morning.
I mean, that seems to be a thread for a lot of this in morning times.
And as you can see, early in the morning after a meal. Okay, so this was the knowledge you shared with us, and we think, okay, so if I'm identifying what makes it worse, let me also see what makes it better. And again, highlighting that it could be something very specific to you. And then there's things that we know that we will also share with you here. The non-pharmacological strategies that we're going to share with you will also make it better. So, for example, the obvious, which is slowing down when changing positions, which is a challenge, and I have something to say after about the sitting and standing slowly. Okay, so in factors that people identified that alleviated was sitting still and waiting, pausing a moment, lying down, going to sleep, okay, and mitigating with medication. So there's specific medication that is used to deal with this. That's true. Let's not get into details. So being well hydrated, drink more water after eating, more salt. Yes, these are all strategies that have been identified. Using compression stockings, hydrating, salt. Interesting one, climbing stairs. So some exercise that is raising the legs, which is also in line with techniques that we know. And then sitting down or staying hydrated. Okay, so there is a good level of knowledge among you about this problem. We were intrigued also to know, okay, so what do people specifically do when it happens? And if that corresponds to what we teach people to do. So we want to this mismatch about what you guys are already doing and what does the research and the clinicians say. Let's start with what people said. I have him sit on the side of the bed for a few minutes. He always uses his walker when getting out of bed. Another person said, I sit immediately, or help the person to sit down. You will see this word often, the sitting, right? Get him to sit down, hold on until it passes, stand still until the feeling passes. Which kind of like, okay, should I sit down or should I just hold on, right? Wait a few minutes till it passes. I do nothing. Hold them, put a chair behind them and offer water. Take his blood pressure. Okay, hold them up, put a chair behind and offer water. Okay, the keyword water. Try to get his walker or a chair close to him. Stay nearby and suggest sitting, deep breathing. Okay, so these are all strategies because remember how we all learn from each other. So I think when it's these type of phenomena, it's very interesting to share in groups. And this would be what I would say usually you will hear health professionals talk about, this dilemma about lying down or not, sitting down or not. And it's interesting in Parkinson because people tend to not like to sit down. And I say that because it's a lot of a job to get up again, right? We know that sitting and standing is one of the tasks that are that are impaired right from the beginning of the disease. And so telling someone to sit down means they will think, oh goodness, then I'm going to struggle to get up again. You get it? So it's usually a runaway behavior that I see in transportation. So people's like offering the place for the person to sit down and they, no, because it's harder to get up. And so this is, the question is like, why wouldn't people sit down immediately when they're feeling woozy, right? It's a question of safety. So we can understand that people want to hold on, but if you really want to be preventive, proactive in dealing with this, the ideal recommendation would be try to hold on quickly onto something and sit down, right? Don't provoke your brain, I would say. And then if we think that the issue is not passing so quickly, you can have strategies like lie down and elevate your legs above your heart rate, right? Which is, again, any recommendation that we give has to be feasible. It has to be easy for people to apply in daily life. And sometimes I must say that health professionals don't think a lot about this. Oh, you know what? Go do this. And when you do an emergent situation, you have to be very practical. We don't want people to faint. We don't want you to manage this problem only when fainting. And the risk for fall is real. And that's why we'd highlight this need for sitting down. If I sit down, then maybe I can calmly drink a cup of water, and then I will slowly get up and then I can continue my daily activities, right? Whatever I'm doing. Other suggestions would be in the moment. So we're thinking in the moment. This is happening at this moment. Would it be recommended for the person to eat something salty? So it doesn't show up in the recommendations. It's something that we want people to ask that strategy with their health professionals, because we don't with the doctor that's following you, because the intake of salt obviously has to be something that has to be in the context of your particular situation. Okay. And then there's something else, which is some activities, and this is where I think the message that I was saying, that sometimes we teach people these tricks and we might not be thinking I would say clearly as well. Maybe we're having foggy thinking about how much do you think a person with Parkinson can go down like that and squat, like in the squatting position, or put a foot on top of a chair, or if we look at these positions, it's true, they work, they help the blood flow go up again, so they exist. As a physiotherapist, I look at these positions and I worry about they placing people in an unbalanced situation, right? So if I had to choose one, I'd probably choose C, as you can imagine. I think E will require much effort to get out of. I think D places a person in balance and unbalanced situation. And you know what's happening in A? Simply what the person is doing is contracting his buttock muscles, maybe if I'm choosing the right word here, his muscles in his butt. So he's pressing it one against the other, and so that we can get those big muscles to contract and to keep the blood going up.
I wonder if the person walking up the stairs is getting some of that benefit from that too.
So when I saw that that person highlighting the stairs, it's probably just getting the blood flow going from the legs to the brain. So it's in line with this D situation. What do you think? You all agree? It's nice positions for. I have to challenge all the people with Parkinson that I have to do these movements. But okay, imagine you are in a line waiting in a supermarket and you urgently need to control the situation. You are unable to get out of the line. I think definitely an E. Okay, just go closer to. You don't have a chair. It's just people will understand if you're going down, right? A B, okay, yes. Maybe B before E, but this now sounds like a dual task exercise here. But I just want to highlight.
Why not A though? Why not A if they're standing in line?
Yeah, you know why I'm running away from A? Because I think it's very hard for people to understand the movement. So maybe it's a good point that you highlight, which is if you are in contact with health professionals that can help train these movements, that would be interesting as well. So they can help you understand what exactly is happening in A, right? Contracting so that you really feel that the muscle is working. I think it has to be taught. It's not something that I think that me just saying it here will be able to explain it.
You mean there isn't an app for that? Yeah, go work with a therapist. Yes.
Yeah, if you are dealing with this, just any health professional should know these movements so they can work with you and train them a bit with you. Okay, so. Yeah, I mean, another question that we wanted to see with people.
Again, this is I always think the value of the surveys is we get to kind of hear the voices. So until this person was able to stabilize the orthostatic hypotension, it really had an influence on all these activities. It was always something that they had to be on guard for. And this is really why it's important to get interactive with your doctor quickly. Start the conversation, because there's a lot you can do to treat it. Some of it's pharmacological, some of it's not. Again, this is another problem because you don't know when it is going to appear or how severely it's going to appear. So it really had made it hard for them to commit to social activities because they didn't know whether they're going to have an issue that day.
And there were a lot of answers. We had to select some. So these are some for you. Again,
now here's someone who's using a walker to keep themselves safe if there's a problem. Watching constantly, and again, these are all things that say to me, it's like it's a really significant impact on quality of life. So definitely worth addressing with the doctor as soon as you can.
And I would probably like the walkers where you can actually sit on them, right? There's a slight sitting.
Sure, like a rollator that has a chair on it.
And learning how to do that, because it also requires some training.
Yeah, and again, high anxiety for a care partner, it's one of these things where they're probably observing changes cognitively that maybe the person, Kirk in this case, is not noticing themselves, but they're able to go, oh, he's getting quiet, he's breathing heavy, got to be extra on guard. It's very scary, it's frightening.
The breathing has been reported, but it's not so often.
Yeah, everyone figured. Okay, so yeah, having falls, I mean, frankly, falls are the most important thing to address. They're the most dangerous thing that can happen in Parkinson's for whatever reason. And again, it's not always possible to address them. That's why you want to work with a physiotherapist. But here's one where if you can address these fluctuations, you can take this. I won't say you can resolve it entirely, but typically you can stabilize this pretty effectively with medications and the non-pharmacological stuff.
And being obviously falling a concern, so we were curious to ask you, how often this was happening, fainting, right? Getting, if you faint, and then I can imagine the panic of the care partner, the understanding, should I call 911 or what shall I do with this? Imagine the person that just said every day, right? If this is happening every day, you're not going to be calling 911 all the time. So it's knowing the phenomenon is very important so that you can triage what. Obviously, we call 911 always when there's a fall, when you hit your head, right? So let's put extremes here. But trying to not get there. Interesting from the results, 62% the people said no, this hasn't happened. It hasn't gone to that extreme. I think we have like a notice. So you start feeling woozy, right? You start feeling, so you have a few moments, a few seconds to work to. It's like an alert, right? The brain is alerting you, take action. And so if we can take action on holding on to something, then it doesn't get to this point. So hopefully it doesn't. But if it does, how can I prevent, have people thinking about this? If I do fall, is there something that I can do, right? And the results say, no, not needed. I use a cane or a walker, something to prevent the falls. Use a cane, hold on to furniture, hydration, again, the salt, removing obstacles, things that we would normally do for falls. And I think these ones are challenging because it can happen very unexpectedly, as you can see here. Measures like if you are someone that is suffering from low blood pressure in changing positions, maybe considering not taking stairs could be an option, right? Because imagine something happens while you're going up the stairs. There's things that we can do about it, like what do you do in your daily life that puts you at danger, and what can I eliminate or find a different way to do it. Okay, so what we want to go from here is to share with you the several strategies, and I would imagine that you probably heard probably the majority of these strategies, and we've already touched upon many. But if one is new and helps you, this is the point of the presentation, is to organize this information for you. So we'll go into these life changes that we are capable of. What are these non-pharmacological things that can help us alleviate the problem? And there's a whole bunch of a list of do's and don'ts. And this really surprised me. The list became really long at a certain point, and we had to cut it down. But keeping it nice and simple is the one that you will hear, okay, so this happens when you get up quickly. That's true. If we get up too quickly, this might. So maybe the solution is, stand up slowly, which is interesting for anyone here that usually does. Hopefully you all doing exercise in Parkinson, and one of the main things that we train in Parkinson is sitting and standing, and we tend to, as instructors, to push you and like, do it faster, right? Or do it big, right? The key word. And big is pushing yourself off the chair. I'm sure you've all heard these words. It's a way for us to train sitting and standing. That's true. It made me question, when I looked at this, it made me think, we should reconsider these instructions for anyone that has low blood pressure. because on one hand, if we want people to be able to train how to get out of the chair with effort, but also should we be training people to get out of the chair slowly? Okay, so this was a provocative thought that came out of this talk. I will train and get back to you on that. So it's how can we use these tips and strategies that we teach you to get out of the chair with a little bit more rationale about how can we do it. Holding on to the arms. Sometimes I do have like colleagues that don't use the armchairs. And in this case, I would say always use the armchairs, right? So getting up slowly implies that you are distributing the effort between your legs and your. Another thing that I would probably suggest is moving before you get up. Mm-hmm. I have quite a challenge to convince people to do this because, again, it's almost like the water. It's so obvious. It's so simple that people maybe don't believe so much in it. Or when I say believe intrinsically, it's not like you questioning if we are saying the truth or not, but it seems so simple that we don't try it. So, which means, kicking out. If you just moving your legs, right leg kicking out, left leg, about 10 movements would be enough to get the blood flow going, right? That could be a strategy before getting up that might prevent the situation.
It's like you're priming the pump. You're getting, the issue is a mismatch with your autonomic system turning on the extra heartbeats you need to keep the blood flowing. So you're just getting it used to like, hey, we're about to do some stuff. We're about to do some things.
And it's something that also in the morning before getting out of bed, if you were able to do this, it would be also beneficial. And not only for blood pressure, but also for activating and for movement as well. It facilitates a lot. I did have someone answer me that says, you know what, but when I wake up, I need to go to the toilet as quickly as I can. So there goes my strategy, right? So again, we can think of creative ways to help. But if you don't have to go urgently to the toilet, then this strategy applies well. Here's another one. So as thinking of prevention, if I do use a shower, which ideally it would be a shower, I think facilitates reduce a lot of risks. Usually becomes really hot, and this is about being hot. So we already know that temperature might trigger the problem. And if so, when I'm in the shower, is there something that I can hold on to? Is there something that I can sit? Right? So this would be one tip. The bath, using a bath. I don't know how often people are actually using it because it's really challenging to get out of a bath if you really lie down. A bath, I'm sorry, I'm saying it in a more. But being completely lying down in a bath, I think it's unusual for me to hear people doing that, but it does happen. I actually have someone that I treat that tells me he spends a whole hour in this sauna. Now in this it's a bath with a jacuzzi.
Tub?
Yes,
a hot tub. Yeah, okay.
That's how he starts his day, which you can imagine really concerns me because it's in the morning. And he already suffers from this. But can I change that? No, I can alert them, but people are, it's a habit. It's something that he does.
You can take some of the temperature off of the shower. If you like nice hot showers, and I definitely like nice hot showers, you can dial that back a little bit, and that'll have some measurable benefit. I don't think you need to do a polar bear challenge every morning.
But what I'm highlighting is like these strategies exist, and professionals might recommend it, and then if the person uses them or not, that is a choice that exists. We can't change everything, but just being empathetic that it's something that the person takes as a decision. Okay, so we think about more. So we have
the heat here.
What correlates with the heat, avoiding again the hot showers, overcrowded places. I think is also very warm. Transportation in the summer. Sometimes you have air conditioning inside, and then you go out and you get the heat. That would be something that I would remember. Or again in the summer, and then you're also adding in drinking because you're sitting down and you're having fun, your vacation. So you combine several factors. This one we cannot underscore enough, which is how can we help people gain more habits of drinking more water. We can think of having more water bottles in the house, or having one that you really want to finish until the end of the day. Hopefully you're doing this more in the morning. So these are all things you might hear.
I think you start with that for sure. And I think that one quick thing you can do is just when you're taking your medications, just drink it with a full glass of water every time. And just by doing that 3 or 4 times, or how many times you take your meds. And I'm not talking a gigantic, tumbler or like a Mountain Dew commercial. I'm just saying a regular 8-10 ounce glass of water. Make sure you drink the whole amount. You can use a water bottle that has some marks on it, so that you're trying to get to a certain goal, and that can be valuable. But it's not such a great idea to drink large quantities of water. Oh, I'm behind. I need to finish this off and drink a half a liter of water, because your body won't process it very well. Just a nice full glass of water, 8 ounces, 10 ounces, 12 ounces. Nothing crazy.
Okay. Then we have I've mentioned this before, it's like if you're in such a situation where you're in a standing position, we have to find a way to, have a little chair or have something that you can take over your shoulder and use. Just be aware that this can happen. And so the salt, we mentioned that this is something that should be discussed, right? With your health professional that follows you, so that you can see how can you increase it, right? And
it can be a little snack too. It doesn't need, not like you need to add salt to every meal, but it could just be some potato chips or pretzels or something just on the fly. Just to give yourself a little bit of a stimulus. Bearing down, a Valsalva-like movement means when you hold your breath to make effort. You can do it sometimes when you're lifting something really heavy. You valve here and you use it to stabilize or when you're in a bathroom. And those things can really wreak havoc to your blood pressure and cause one of these real quick fluctuations that will result in you having an episode that could have you blacking out. This little footrest up here, if anyone hasn't seen the commercials for the squatty potty, it's kind of that same thing. By putting your feet in an upward position, you're improving your posture for going for having a bowel movement. So it's something to look into. Mm-hmm. Quick and simple solution.
Yeah. Reduce the effort, right?
Yeah, reduces it. Compression stockings are something that are often recommended, but we actually, when you look into research, unless they get up to your abdominal area, they're not that effective. Actually, an abdominal binder like Spanx is actually probably more likely to be valuable. If you're having trouble getting them on, they do make compression stockings that do have zippers. Again, if you're using them, you want to get them up to your belly level. And then, of course, if you're lying down, you want to take them off, because you have the risk of increasing what we call supine hypertension. When you're lying down, you can have high blood pressure, so you don't want to use them when you're sleeping. You use them only during active times. Again, with the meals, you run into an issue where after you eat a meal, you spend there's additional blood that goes to the stomach to help with the digestion, and that will actually influence and increase your hypotension. There could be a little bit of processing the high carbohydrates, a little bit of insulin processing, which also lowers your blood pressure. So instead of having large meals, more frequent meals, particularly meals that aren't high in sugar and other carbohydrates. Obviously, alcohol is not fantastic. And caffeine, you would think it would increase your heart rate and it'll make you more alert, but it is a diuretic, meaning it lowers your liquids. It makes you excrete liquids. So over the long haul, excess caffeine doesn't do much for you, except you make you more dehydrated.
And if you're suffering with this with the large meals, then just making smaller meals is one of the recommendations throughout the day.
Absolutely. And same for GERD, and same for a lot of stuff, for fatigue and everything.
Yeah.
So again, when we're talking about orthostatic hypotension, quite frequent among people with orthostatic hypotension whose blood pressure drops when they stand, when they're lying down, they tend to have higher blood pressure, and it becomes a real conundrum. And typically what you do is you get a wedge pillow that puts you up at 20, maybe 30 degrees, and that allows you to avoid that problem. So you can manage the high blood pressure when you're sleeping and the low blood pressure when you're upright, when you're standing upright. Mm-hmm. It's a very common, it's almost so common, I would almost say anybody who's dealing with orthostatic hypotension should prophylactically try to address supine, lying down hypertension, high blood pressure.
We read different strategies. I think one of that I found very original was like the person taking a slight meal before bed so that it reduces.
Yep.
So in this case, we are using the meal on purpose so that it reduces the
But
the
then you
blood
have
pressure.
GERD, yeah.
But if you think about it, okay, but then you're in the night, how is this going to affect reflex and stuff?
Yeah.
But I would say, as a recommendation, as we know, this happens in the elderly as well. So it's just, just no more flat beds, I think, would be a good recommendation for anyone. And this is what we mentioned, the differences between the two, low blood pressure or high blood pressure at night, which makes it very difficult to treat in terms of medication, right? Because that means if we have a hypertension, there's a risk of cardiovascular problems or renal disease or something. So you might have medication for that. And then, but on the other hand, if this is provoking your hypertension during the day, low blood pressure, then you're at the risk of falls. So good sense has to be managed. And when I said the professionals have to communicate, it would be like, maybe I can take my high blood pressure medication at night when I'm going to bed. I don't know if this is a communication yet. You talk with the doctor, but it's strategies. Instead of taking it maybe during the day, that will affect you, lower your blood pressure. Maybe I can take it at the end of the night, right? So when we take it, could be negotiated so that both doctors can be happy. But above all, that you can don't have risks.
When you're getting ready to go into your doctor's office, especially if you notice this issue, you might want to track things a couple of times. And again, you'll want to take your blood pressure while you're lying down, at least for 5 minutes, and then you get up and stand for 3 minutes, and then take your blood pressure again. And you're talking just a regular off-the-shelf blood pressure cuff that you could get at a pharmacy.
Yeah, and we wanted to give you an example of this is a diary that exists. And so it's just making sure to add a specificity to Parkinson in these type of diaries, which is when did you take your medication?
Critical.
So it will be also very important for the health professionals to understand where is your medication when you took the measurement.
Yeah.
So we're almost finishing up. I apologize for the time. This was an example of somebody of how the person is registering at different times in the morning, lunch, and then later in the evening.
Look at that difference in the morning, 190 when they're lying down, 75. So that's a huge change, 120, 115.
So the key message is really being able to register the three and not imagine, oh, this is too much work, right? 2-3 days before you go to the doctor, you have something where you register this, right? Make it meaningful. So that you're not spending too much time focusing on it.
You don't necessarily need to keep a record for months at a time. And I want to say real quickly, technology is changing all the time. Right now, none of these Apple Watches or other wearables is going to be viable. That's probably going to change. You see little bits of research out there where they're using an EEG off of this device to help with this. But there have been a couple of attempts to make an actual cuff wearable, and that hasn't quite worked. This is actually a device that's just a regular cuff, blood pressure cuff, but it puts it onto a phone so you don't have to track the numbers. That's about as far as that goes right now. But, we were talking about watch for changes or improvements in care. This will be one where somebody solves this issue, and then your Apple Watch or your Android version will probably do it. Just not yet today.
Yeah, and important is to show that change, right? Not on this day you had this. I would probably suggest, independent of what you use, it might be interesting to take it to your doctor and say, this is the device that I'm using, compared to what they're using. Usually it's particularly different, but what matters is that change, right?
Yeah.
You just want something that will help you monitor the change. But maybe, doing this as a practical thing so you calibrate it with ease as well.
Exactly. You don't need to have a medical grade device, but it might be interesting to see. Okay, again, just like your doctor's going to ask you about medications and try to do a chart review, make sure you're letting them know all of the different supplements and vitamins you're taking, because some of them could have an influence on blood pressure.
And then I don't have to say much. I'm sure everyone could say the sentence for me. Obviously, exercise always plays a role in any symptom, right? And important so here as well. Keep moving. We were made to move, and so remember, like, standing position for a long time is negative. Yes, it is. Let's move, right? So it's really about the movement and so reinforcing that message. And now to summarize, we had our chart, we complained, we write to the doctor. And so based on all this information, the doctor is able to come back to you and say, you know what, hey, dear John, now let's book a consultation so that we can really assess the problem, right? But it seems like, based on the information that you sent, this is happening after eating. So based on all the information that we just shared with you, look at the list that is possible to do just to control this problem, right? So the person is suffering from low blood pressure after eating, and look at all that we can do. Eat small, frequent meals, consume salt, avoid alcohol, make sure that we have
adequate hydration.
The hydration, or even moving before you're getting up. That was one that I added in. Using the stockings or not, the binders, standing up slowly after eating. And so it's good to see all the solutions that are possible. And yes, with that note, we will, here are some questions, but maybe we should go into the chat and just see.
I haven't seen anybody in the chat, but maybe we can just pull that up here and make sure. Sorry, we went a little bit over, folks. Does anyone have any specific questions or things that we can clarify a little bit? You can either unmute yourself or put it in the chat. And if not, we'll always have this in the, we'll have this on the website for the IPMDC.org webpage. And so you'll be able to pull up this presentation as well as the slides and be able to review anything.
Yeah, I do like to ask for the people that I see on screen, was this useful? You can, yes, no?
Yes, yes.
Thank you.
All right.
It's just trying to be
yeah. I have a question. Can you hear me?
Yeah. Oh, yeah, absolutely.
Okay. Does DBS have anything to do with affecting this orthostatic hypotension?
I think that when you look at orthostatic hypotension, this is really an autonomic condition, and that's where the problem's lying. So I wouldn't put that DBS in that same thing unless it's influencing the autonomic system, and it usually isn't. It's just two different phenomenon. You might have situations where the DBS is influencing your balance, and if you're having this on top of it, it could complicate it. But I wouldn't say the DBS would be a cause.
So
okay.
There's literature regarding that now.
Thank you.
Anybody else? DBS is always something where it's a nice thing to make sure your doctor is aware of the issue, because there might be some parts of the DBS that they can address it with, but it's always its own confounding extra.
I think everything you said was very clear, so we're not asking, or at least I'm not asking for much comment, because I think it was clear when you said.
That's great, Al.
Thank
you, Al. Yeah, good.
It's good to know, right? Okay, hopefully we didn't fail too much.
Yeah.
We want solution. I was actually very enthusiastic about this talk. It's like, that is so interesting that there's so much that people can do. Now we just need to convince them to do it.
Yes.
A global influence. That's what I'm excited about. It's like you can do something about it, control it, and it could have an influence on cognition and falls and other quality of life. And that's where I think it's worth having a conversation.
Well, I had a nasty fall, and that caused me to look into hypotension and things like that. So it was actually a useful fall.
Well, yeah.
Now that's you are a very positive person.
Yeah, no. A useful fall.
A useful fall.
I've heard that before. I've heard
glass
that.
half empty.
Each fall should teach us something. That's true. That's true. I try to highlight that so that we don't fall in it together again, right?
What I was going to say when I came off a mute is this would confirm a lot of the things we're doing to increase our understanding as well of why we're doing those things.
For sure.
Yeah, it validates it, right? It's just like it motivates us to continue resilient in all these changes that everyone keeps telling you to do.
Right.
The questionnaire you sent out, I wondered about how many people did respond.
We had 21 people responding,
21,
which is for questions. Very good. So thank you so much. It's a good sample. Believe me, there are research papers published on this. I'm like, oh, I should use this to publish.
That's another conundrum, but
it's interesting. So we'll transform that into more knowledge, I think. But the talk is then based on that.
I think the surveys really make it valuable because then we really understand what people are coming from directly and we're addressing it directly to what people are saying rather than like, here are all the things that could
All the
happen with,
definitions that exist
here's
for
the world of,
hypertension.
it's like that's,
Yeah.
those presentations are fine, but that you don't get anywhere with them, I
Yeah.
think.
Well, thank you for your time.
Yep, thank you for joining
Thank
us,
you.
everyone.
Thank you for coming.
And thanks for the suggestion. Sonia came in with the question, so thank you for making the suggestion for it.
Yes, well, thank you to the person who's on today who suggested it in the first place. So just to make the point that our programs are based on what your concerns are and the sorts of things we hear and the questions that we get asked. So, you know, if there's something like this that's on your mind that you'd like us to cover, please let us know, because that's why we're here. And I also want to say, Josefa and John, that the bit about the words to use when you go to your doctor's appointment made me very happy.
Yes.
Good.
That was
You did say the word my chart too, so make sure you
When we
put it in
talk
my
about
chart.
empowering people with Parkinson and care partners, I think this is part of it. It's like giving you the right words so that cling, the professionals will listen differently.
Yeah, no, that was great. And also then the response of, you know, here are all the things you could be doing. So yeah, I love that bit. Thank you.
So I have to tell you, I'm from Pennsylvania, and you guys, I wish you were closer. You do a better job of answering questions and getting down to the nitty-gritty, and giving information that is more relevant than any of the other seminars I have been involved in. My husband is a Parkinson's patient for 25 years now. And I really, you know, these are so beneficial. Even with somebody who's had Parkinson's that long, it's still, you can still learn. There's still a lot to learn. So I really appreciate being able to join these seminars, and I thank you.
Very kind. Thank you.
Thank you.
Yeah.
You're
Especially
most
25 years. You've seen a lot of it.
Yeah.
Yes. And this is the third person in my family. My mother, my father-in-law, and my husband. So it's been a long road. A long road.
You don't want to become a Parkinson's pro, but you might be there, right?
Yeah.
Yeah. I'd like to echo the sentiments of the woman who just spoke. My husband has had Parkinson's for 12 years, and I agree that the way that you communicate information far exceeds that of many other seminars, meetings, whatever. And I'm pleased to say that I'm not pleased for him, but a member of my church has Parkinson's, and I've been sharing the information that you give and information about the sessions with his wife, since he seems a little distracted at this point. But I agree that this has been very, very helpful, even at this stage in my and my husband's Parkinson's experience. So thank you.
Yeah.
Thank you for sharing that. Sometimes with questions like this is really useful. You see how I ask that at the end always, because it's a challenge to reinvent. I think if we really want to help with the questions was how can we really help people with the right information, and I think people are feeling really overwhelmed with a lot of information that's out there. So this is always in the back of our head. How can we make this different and more useful? So thank you so much for sharing that.
The right information at the right time. And Sonia just put the link in there for anybody who's looking for it. All the recordings and the slides are available on the IPMDC.org website under the Care Partners section.
We're trying
Thank
to
you.
make it into a library,
you.
so make it easier to navigate for you all.
Yeah.
I didn't write it down fast enough.
Bye.
Thanks, Grace.
Okay. Bye-bye.
Thank you, folks.
Thank you all.
Have a good evening. Good afternoon.
Thank you.
Thanks, Josefa and John.
Thank you.
Thank you.
Have a good one. Bye.
Nice to leave on a high note.
Yeah, for sure.
Thanks,
All right.
Mary.
Take care, folks.
You're welcome.
And happy birthday to the birthday boy.
Yes,
Yeah.
we're going out. We're going out for dinner in a little
Oh my
while.
Ah,
goodness.
there he is. Hey.
There's the birthday boy.
We'll cut this part at the end, guys. Don't worry.
Yeah.
Yeah, no worries. We'll show up on the recording. But yeah, happy birthday.
Yeah,
Yeah, thanks for inspiring us, because
With
this
no
was a
blood
lot of
pressure.
learning. It was good.
yeah. He turned 75 today.
Wow.
Happy birthday.
Yep. Yes.
Thank you.
Hydrate with the alcohol or whatever you're going to do.
And that's something he hasn't touched since being diagnosed. He was diagnosed in 2019, and he hasn't said no. It's too risky.
Probably. Doesn't enhance anything, and it probably makes things riskier for falls, for real.
Yeah, yeah. Thanks again. Even though I'm up in Canada,
Yeah. Okay.
I love seeing your programs. They're great. Thanks again.
Thanks
for
to Sonia
joining
for
us.
making it happen here. Yep. All right, guys. Have a good evening.
Bye.
Great celebration.